Hi, everyone. We're going to get started. Good afternoon and good evening. My name is Sarah DeFeo. I am the Vice President of Scientific Affairs and Programs here at the Ovarian Cancer Research Alliance. And I want to thank you all for joining us today as we continue our webinar series for 2019 with today's presentation on ovarian cancer research updates with Dr. Doug Levine. So just a little bit of background about our organization. Ovarian Cancer Research Alliance is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis, and we work with all levels of government to ensure that ovarian cancer is a priority. So before we get started, just a brief housekeeping note. All listeners will be in a listen-only mode throughout this presentation. We'll have some time for questions afterwards. So if you think of a question as you're listening, you can type it into the Q&A box that is in the lower right-hand side of your screen. I will see the questions, and I will select some to ask Dr. Levine at the end of the presentation. You don't have to wait until the presentation is over to submit your questions. You can type them in as we go along and as you think of them. And this webinar is being recorded, so this audio and the slides will be available on the OCRA website starting, I would say, tomorrow or maybe the day after. But we'll let you know. We'll send an email and let you know when they're up. So a little bit about our presenter, Dr. Douglas Levine. Dr. Levine is the Director of Gynecologic Oncology, Head of the Gynecology Research Laboratory, and Professor in the Division of Gynecologic Oncology at the Perlmutter Cancer Center at New York University Langone Medical Center. He's a gynecologic oncologist who specializes in the surgical treatment of women with either known or suspected ovarian or uterine cancers. He's also a prolific researcher and educator, having co-authored or authored more than 200 peer-reviewed research papers and articles. His research has been supported by funding from the National Cancer Institute, the Department of Defense, Stand Up to Cancer, OCRA, and others. He's the recipient of many honors and distinctions, and he's a longtime member of our Scientific Advisory Committee. And he's also serves on the boards of several other organizations. He's been awarded the American Congress of Obstetricians and Gynecologists Mentor Award, served as co-chair of the American Association for Cancer Research Special Conferences on Ovarian Cancer, received the 2013 Foundation for Women's Cancer Excellence in Ovarian Cancer Research Prize, and he's the Assistant Dean of the Department of Defense Ovarian Cancer Academy. So we're thrilled to have him here with us tonight. So Dr. Levine, I will pass the ball to you, make you the presenter, and you can get started.
Thank you, Sarah, and good afternoon and good evening to everyone. Let me just get this set up here. All righty. That should be working, Sarah. Yep. And you can hear me okay?
Yep, you sound good.
All right, good. So again, thank you all for joining us tonight. Over the course of the next 40 minutes, I'll try to give you some updates on what's been going on in our research environment since the beginning of 2019. Most of our research meetings happen in the spring and the summer, and so this is a good time to do this, which we have been doing for a couple of years now. Let's see, how's that going to work? Oh, there we go. Okay, so I'll start with a little basics of ovarian cancer to make sure we're all on the same page, then move on to some new developments with chemotherapy, some new developments with Parp inhibitors, some new developments with combinations of targeted agents, cancer prevention trials, and then we'll have some questions and most likely some answers. And I want to remember to thank all the patients who have participated in these very many clinical trials that I'm going to present, and also others that I will not be presenting, because this is the way we make the future of cancer care more successful. And I also want to put out a thank you to all the presenters whose slides I have borrowed, using that word loosely, for this presentation, but they are in the semi-public domain. So ovarian cancers are not one disease. There are many diseases. This is a slide from the report on the state of the science of ovarian cancer from the Institute of Medicine that we published in 2016. And you can see the most common types of ovarian cancer are listed at the top of the slide. High-grade serous carcinoma is the one that most people are familiar with, although many people will be familiar with endometrioid carcinoma, clear cell carcinoma, carcinosarcoma, low-grade serous carcinoma, and mucinous carcinoma. Certainly high-grade serous carcinoma is the most aggressive and the most common. Endometrioid and clear cell are the second two most common types, and they can sometimes be aggressive. Overall, they are somewhat less aggressive, but still troublesome. We know a lot about all these cancers, but particularly we know about high-grade serous because we've studied that extensively, probably the most extensively, and we know the molecular composition of high-grade serous carcinomas, and we know there's many Brca mutations. They can be in the germline, which means they're inherited, and they're in every cell of your body, but they're only causing an effect in the cancer cells. They can be somatic, which means they're only located in the cancer cells. The gene can be turned off by a phenomenon called methylation, which is very similar to inactivation of the gene. There's other genes that we'll talk about towards the end. All these genes have an effect on a process called DNA repair, which we call homologous recombination. And when there's a defect in one of these genes, we call it homologous recombination deficiency, and that's also a biomarker for response to Parp inhibitor treatment. And then other tumors that don't have any of these gene defects often have something called a cyclin E1 amplification, which is actually associated with resistance to chemotherapy. So that's a big problem that we're working on and have not yet found a very good solution. And then we also know about some other molecular components of the disease. Just while I'm starting out, I'll just reach out to Sarah. You can still hear me okay? I know she's on mute, but just want to double check.
Yes, I was on mute, but I
saw you
can hear you
just double checking, so I'm not talking to myself. All right. So
yep.
So where do the cancers come from? So we used to think that ovarian cancer came from the ovary. We now think that most of high-grade serous carcinomas come from the end of the fallopian tube. This is a slightly controversial area, but most of our people in our profession believe that the data that's been accumulated over the past 10 years strongly suggests that ovarian cancers actually begin at the end of the fallopian tube, at least high-grade serous carcinomas. Low-grade serous carcinomas may begin in the ovary. They may come from ovarian cysts. They may also begin in the fallopian tube sometimes. We're not entirely clear on that. One thing we're also pretty clear on is that clear cell carcinomas and endometrioid ovarian carcinomas grow out of endometriosis. And endometriosis is a phenomenon that mostly comes from retrograde menstruation, which means that when you're having a period every month, instead of having normal menstruation, some of the endometrial lining can shed actually out the fallopian tubes into the pelvis, onto the ovary. It can develop endometriosis, which is certainly a problem on its own. It can lead to pelvic pain. It can be very bothersome for a fair portion of the population. And sometimes it can turn into cancer. The risk of getting these cancers with endometriosis is only a few-fold increased, and the risk of these cancers in the population is quite low. So we don't have risk-reducing strategies to prevent these endometriosis-associated cancers, but we are pretty confident these cancers come from endometriosis. And we're not entirely sure where mucinous ovarian cancer comes from, or some rare cancers, such as my favorite rare cancer called small cell carcinoma of the ovary, hypercalcemic type. We know a lot about the genetic mutations in that disease, and a lot of our progress has been made by support from the ovarian cancer community, such as the people who are on the webinar. But we are pretty confident where high-grade serous carcinoma comes from and where the endometriosis-associated ovarian cancers come from. And my last reminder, I think, is just to remind everyone that all women with ovarian cancer or a first-degree relative with ovarian cancer should be tested for BRCA1, BRCA2, and other select germline mutations to see if there's a gene that could be inherited in the family that could be passed down to children, and therefore opens the opportunity for cancer prevention, because we do have very good ways to prevent ovarian cancer that often involve some type of a surgical procedure, but sometimes can involve medical treatments such as oral contraceptive pills. This testing is usually covered by insurance. There's no discrimination for medical insurance. It's a simple blood test or a saliva sample, and it really is a great way that we can save lives and prevent people from getting ovarian cancer. The basic treatment for ovarian cancer is usually surgery, sometimes chemotherapy first if we can't do surgery, but usually it's surgery followed by chemotherapy and followed by a period of observation where we measure a biomarker called CA-125. We often do CT scans, and if cancer comes back, then we usually treat with chemotherapy again, and sometimes we'll do secondary surgery in select cases where it seems to be beneficial. So getting on to the research, I'm starting with some chemotherapy trials and actually starting with another rare tumor that I study. This is a tumor called a carcinosarcoma. It's actually a cancer or a carcinoma that has turned into a sarcoma, so it has features of both a carcinoma, which is called an epithelial tumor, and a sarcoma, which is called a mesenchymal tumor. These tumors, unfortunately, are fairly aggressive, and they're not that common. They account for about 5% of ovarian cancers and also 5% of endometrial cancers. They are a little more common in the uterus, but they do occur in the ovary, and this is a webinar on ovarian cancer research updates. And so a phase 3 trial that took about 10 years or so to complete, led by Matt Powell from Washington University in St. Louis, was reported at ASCO. And here, over the course of a number of trials, we had developed a standard treatment with 2 drugs called paclitaxel and ifosfamide, but it was a fairly complicated and toxic regimen, had some small risks of some very serious neurologic side effects, and it wasn't a great treatment that we liked to give that much. And Taxol and carboplatin was a treatment that we used all the time. It's given to almost every ovarian cancer patient. It's used for lots of other cancers like uterine cancer and other gynecologic cancers and non-gynecologic cancers, and it worked pretty well. And so the question was, does it work as well as this regimen that was more difficult to administer? And so they did a study of women with newly diagnosed or recurrent carcinosarcoma of the uterus or the ovary. This is sponsored by our cooperative group called NRG Oncology, which is a outgrowth of what you might know as the GOG Oncology clinical trial group. A couple of clinical trial groups came together, now called NRG Oncology. This is the study called GOG 261 because it started when NRG was actually GOG. You can see the regimens here. Patients were randomized to receive one of the 2 drug regimens that are here. On this slide, there were actually 500 plus endometrial cancer patients enrolled and about 100 ovarian cancer patients enrolled. This is somewhat of a tricky diagnosis, so there was a central path review, and some cases were found to be misdiagnosed or didn't meet all the diagnostic criteria. And then patients received treatment and were followed. This is the outcome for the ovarian cancer patients. It was a small subset, but the bottom line was that neither treatment was better, or the investigational treatment called Taxol and Carbo was not worse or not inferior. And this is actually the same finding that was seen in the uterine cancer cohort as well. And the Taxol Carbo was slightly better tolerated also. And so the bottom line of this first small rare tumor study is that Taxol Carbo was not inferior. In fact, in uterine cancer, part of the data showed that it was actually better, but the toxicity was similar. It was easier to administer, and so basically for carcinosarcoma as first-line treatment, Taxol and Carbo is now the new standard regimen, and ifosfamide can still be used and still has activity and will be used in the cases where the cancer may come back and need more treatment. The next study is really a fascinating study. It's done by a European cooperative group. It's a randomized trial to compare different regimens as they relate to treatment of older women with ovarian cancer. The thought being that, older patients often are as fit and maybe can't tolerate chemotherapy as well. And in fact, there was some data that suggests that. And so this study actually accrued people who met a score, something called a geriatric vulnerability score, which basically is an assessment of activities of daily living. Can you cook and clean and shower and dress yourself and go outside, and how much time do you spend in bed, and anxiety and depression and nutritional status and all these things. And basically, if you had a score of 3 or higher and you were more than 70 years of age, it suggested that there was some, performance compromise, and you maybe were not perfectly healthy. And so it was trying to accrue older patients who also, were not necessarily as healthy as possible. And so they randomized patients to 3 different treatment arms. One is the standard Taxol and Carbo, that's arm A. Arm B is something called weekly carboplatin, what we call single-agent carboplatin. And so in Arm B, for some people where we think they may not be able to tolerate the chemotherapy completely, we would just give carboplatin alone with the idea that platinum is the most important drug. It's been around for the longest time. We know it's like the most important of the 2 drugs, and so we should just give that drug alone because you're getting the best drug and you're saving some toxicity. And that's a very commonly held belief among GYN oncologists and medical oncologists who treat ovarian cancer. And then the third arm, Arm C, is weekly treatment. And so, again, there's this debate as to whether giving chemo weekly works better. And so these were the 3 arms that were being compared, and patients were randomized. You can see there were about 40 patients in each arm. The patients were on the older side. The average age was about 80. And some other data is shown here as well. This is interesting, is that, again, you can see at the bottom of the slide, So patients were allowed to have surgery first, and about 2/3 of the patients did have initial surgery. And as some of you may know, the goal of surgery for ovarian cancer nowadays is to remove all the surgery that you can see with the naked eye. And you can see at this bottom row here that less than 10% of the time could the surgery be complete, meaning could the surgery remove all cancer that could be seen with the naked eye. And normally we can do this about 50 to 75% of the time. But in an older population that's not necessarily completely healthy, it's rarely done. And that also begs the question as to whether, surgery, is indicated if you can't get at all the cancer. And most of us would say you wouldn't try to avoid surgery unless you can get at all the cancer. So about a third of the patients here did not have surgery. They had chemotherapy first. And of the people who had surgery, very seldomly could all the cancer be removed. Now, that's not the point of the study. The point of the study is, can you receive all the chemotherapy? And you can see on this slide that for the single-agent carbo, which was supposed to be the drug we're using, so that it's not as complicated and doesn't have as much toxicity. In fact, less than half the patients could complete all 6 cycles of the arm that was supposed to be the easiest to tolerate. And the other 2 arms, about 60 to 65% of people could complete all 6 cycles. You look at the side effects of the drugs. The single-agent carboplatin had the highest level of anemia. The weekly paclitaxel, the highest level of neutropenia or decrease in the white blood cell count, and that's also been known. And so there's different side effects for the different arms, and about 15 to 20% of people had to stop treatment due to side effects or toxicity. And then you look at the outcome, and the main takeaway is the single-agent carboplatin that was supposed to be the most important drug actually performed the worst. And this study was actually stopped early. That's why there's only 40 patients or so in each arm, because it was stopped early because it was statistically determined that this arm was inferior and patients should not be continued to be put on this arm because it was not doing as well. The other two arms had no statistical difference. It was also determined that even if the trial went on and lots of more patients went onto both arms based on what was being seen, it would not be possible to tell which of these two arms were better. And so the trial was stopped, and the take-home message is that comparing these different regimens, single-agent carboplatin was less active and had a worse survival in the population where it's actually supposed to, be the best tolerated. And so this is my comment up here. For some of these results of clinical trials, we have these long-held beliefs of what we're going to do to, help our patients, and even with the best intentions and, smart doctors doing this all over the world, I subscribe to this, this idea myself, that we do single-agent carboplatin when we think someone might tolerate the two drugs, and now only from the clinical trial, we actually learned that we were wrong and we may not have been helping people as much as we can. And clearly, the two drugs together, given every 3 weeks, seems to be the best treatment for people who are of really any age and any performance status. Moving on to the next study. Actually, this is a little segue. I talked about Energy Oncology, which is our clinical trial group. We're actually planning another study to figure out whether surgery and chemotherapy is better than chemotherapy alone for older women who have already started treatment with neoadjuvant chemotherapy. This study is not open. This is just a concept that's being planned by Dr. Ahmed from Northwestern, I think, working with Dr. Bill Tu from Memorial Sloan Kettering. And the idea is that there's limited data about what treatments are best for women who might not be great surgical candidates or who can't tolerate surgery. And a pilot study that was done of people who received chemotherapy first and who were over 70 years of age showed that almost half the time they did not go on to have surgery at all. And when you control for various factors, it was not clear that in this particular group the surgery made a big difference. And so the study that's being proposed and will likely be changed and is not finalized and won't open for a while, but the idea is that, in women who are over 70 and may have some performance status compromise, after giving initial chemotherapy, should you just stick with the chemotherapy and never do surgery, or should you do surgery, and which one will both improve survival and also have differences in physical function or basically performance status and outcomes and quality of life. And this is a really important study to figure out where is the best role for surgery and which patients will do just as well having chemotherapy without surgery. And again, this is just being planned and is under discussions and will undergo some modifications before it opens in a little while, in quite some time actually. Okay, so moving on to Parp inhibitors. And so most people know that Parp inhibitors work pretty well for women and tumors that have mutations in BRCA1 or BRCA2 or other related genes. We use it for maintenance therapy nowadays. That result came out last fall and was very strong and rapidly became a standard of care for everybody. But the question is, if you have a recurrence of the ovarian cancer in what's called platinum sensitive, which means you haven't had treatment in more than 6 to 12 months, at that point, if you have a BRCA mutation, should you just get a Parp inhibitor such as olaparib, or should you get chemotherapy first in this situation? This is called the SOLO3 trial. Presented by Richard Penson from Mass General Hospital. And basically, patients were randomized in this situation to get olaparib, or what we call dealer's choice, which means the oncologist and the patient would decide together what's the best treatment, and often it would be doxorubicin or Doxil, liposomal doxorubicin, Taxol, gemcitabine, or topotecan. 2-to-1 randomization, so twice as many people have received olaparib as received the standard chemotherapy. You can see there were about 250 to 300 patients in the study. Most patients, well, all patients had BRCA1 or BRCA2 mutations, about twice as many BRCA1 mutations as BRCA2, and this is what we see in ovarian cancer. And most cases were high-grade serous. About half the patients received Doxil as the chemotherapy drug. And then here you can see the differences in that for BRCA-associated ovarian cancer, getting olaparib alone seemed to be better than getting chemotherapy. You can see the different curves and the different numbers. We like to focus on hazard ratios, and basically the olaparib was almost twice as good as the chemotherapy. And so for someone who hasn't received a Parp inhibitor before, which may not be so applicable anymore now that we're using it in the maintenance setting, but for anyone who hasn't received a Parp inhibitor, if their cancer comes back today, we would recommend a Parp inhibitor over chemotherapy for someone with a BRCA-associated ovarian cancer. This study also reported on side effects. And here you can see the side effects from olaparib or the Parp inhibitor were about the same overall as chemotherapy. So about 50% of people had a serious side effect called a grade 3 side effect. About 20–25% had more serious types of grade 3 side effects. And this is a really great study to compare these two things, because don't forget olaparib, I'll show you here. Olaparib is a pill. It's a couple of pills you take twice a day, and everyone thinks, great, it's just the pill, it's oral, it's an oral agent, that's wonderful, and you don't realize it's actually, real chemotherapy. And here you can see some of the adverse events or side effects from chemotherapy and olaparib, which is just oral treatment, which is often preferred, but I'll call your attention to anemia. And this dark green bar, that's 21% of patients had grade 3 anemia, which means their blood counts went very low, often requiring blood transfusions, and that was more common than getting, intravenous chemotherapy. And then here for fatigue or weakness, again, more common with the oral drug. Neutropenia or white cells going down was common in both arms, a little more common in the chemotherapy arm. And again, lower platelet counts were more common in the olaparib arm. And so, it's important to realize that olaparib is a great drug, as the other Parp inhibitors are. They actually work. They work really well. It's great to just take a pill, once or twice a day, but it's real treatment. It's real chemotherapy, and it has real side effects, but also it actually really works. And so SOLO3 is a first randomized trial comparing a Parp inhibitor versus chemotherapy. There was a benefit to the Parp inhibitor. The tolerability was similar, but although different among arms overall, the frequency of side effects was similar. But it's just a great study to highlight what it's like to take an oral chemotherapy agent. Also, an important study to show in this situation what the best treatment is for BRCA-associated recurrent ovarian cancer. So the next study looked at combining a Parp inhibitor with an angiogenic inhibitor called bevacizumab. This targets blood vessel formation. And the question again is if ovarian cancer comes back and it's platinum sensitive, and this is not selected anymore for BRCA mutations because niraparib is approved for treatment of BRCA-associated or non-BRCA-associated ovarian cancer. But if you add bevacizumab, is that better than niraparib alone? And so patients were again randomized to the pill niraparib, which is taken once a day, and niraparib with bevacizumab. About 50 patients in each arm, average age of 66. You can see here in the middle of the slide, about 30% of patients had a BRCA mutation. About 60% of patients had a defect in the homologous recombination repair pathway, or they had HRD positivity. Some people had received prior bevacizumab treatment. That was acceptable. Here you can see the outcome, and so the combination of the two drugs was better than the one drug alone. So that's an important outcome. It was about twice to 3 times as good, taking the niraparib, the Parp inhibitor, with the anti-angiogenic inhibitor, the bevacizumab. This is interesting, is that you can see the largest benefit was seen in what's called the BRCA wild-type group. And so this is a group that does not have a known BRCA mutation. There was a small but non-statistically significant benefit in the BRCA mutated group, and I'll explain to you why I think this was the case. So we know that Parp inhibitors work best in tumors that are BRCA associated. So the idea here is that the Parp inhibitor alone is working much better, and so the added benefit you get with the bevacizumab is not as great, whereas here in the BRCA wild-type group, the Parp inhibitor does not work that well on its own, and so adding the bevacizumab allows the two drugs to work together, and then you see more of a benefit. And so that's the thought process behind that. Again, I'm going to skip this in the interest of time, but similar side effects. Single agent Parp inhibitor also can lower your blood counts, even though it's an oral agent. And so you'll conclude, and the authors concluded that niraparib and bevacizumab was well tolerated. Compared with niraparib alone, the improvements were statistically significant in outcomes, and that's great. And I agree, that's true. But the question that is unanswered is what I put here up at the top. So, the study didn't look at taking niraparib and then taking bevacizumab afterwards. And so, one thing that's not entirely clear is if you took the niraparib and then followed it with bevacizumab, would you ultimately, do just as well as taking the two drugs together? Would there be less side effects? There's some thought that sequential therapy, taking one drug after the other, can lead to good response but lower side effects. And obviously, if one arm is only getting one drug, the other arm is getting two drugs. Both of the drugs are active agents for ovarian cancer, so it's not such a big surprise that in the BRCA wild-type population, the two drugs will work together. What an interesting study would be is to look at the two drugs together compared to the two drugs one after the other, and then see if those are the same and how the side effects might be different. The next study was another demonstration of why it's important to do clinical trials. This is a study of avelumab, which is an immune checkpoint inhibitor. And so these drugs unmask the tumors so that the body's own immune system can attack the tumor that's growing. And so the question is, if you give a checkpoint inhibitor alone or in combination with a chemotherapy agent, does that sensitize the response to the immunotherapy? And how do those three arms compare? This is from the series of Javelin trials that tested a drug called avelumab, shown here, avelumab. It's a three-arm trial. You have the immunotherapy alone, you have the immunotherapy with chemotherapy, and you have the chemotherapy alone. This trial was big. It was about 550 patients or so, average age of 60, so a little younger here. You had to have, again, platinum-resistant disease here, or you would have received platinum, of course. So this is for patients where the platinum drugs are not working that well anymore. And here you can see that the overall survival was no different. And so adding the two drugs together was not better, was more toxic, and was no better than the chemotherapy alone. And so again, we learned here that, all checkpoint inhibitors probably do not work the same, and different combinations of drugs are going to certainly have different outcomes. Again, the side effects are interesting to look at among these trials because they really sort of quantify the expected toxicities of various types of treatments, such as immunotherapy versus chemotherapy. This slide shows the overall side effect profile, and I don't really want to spend too much time talking about that, but on this slide here, this shows the immune-related adverse effects. So we know that checkpoint inhibitors can have very unusual effects because as the immune system is trying to target the cancer cells, it also can have the bystander effect of targeting some of the body's normal cells. And so common things that are seen are thyroid gland disorders because it can target the thyroid gland tissue. It can target the liver and you get hepatitis, which is inflammation of the liver. This is not a viral hepatitis. This is an immune-related hepatitis. You can get pneumonitis, which is like pneumonia, but again, it's not infectious. It's from immunologic treatments. And then colitis or diarrhea. And these are the most common side effects with immunotherapy. And they occurred in a grade 3 or greater, which is the more serious types, 4% of the time with the immunotherapy alone, 8% of the time in combination, and very rarely did the chemotherapy alone give you any immunologic side effects. And so this 4% is pretty consistent. So there's a very small number of patients who will get these are very serious side effects. We treat them with high-dose steroids, and if we don't treat them with high-dose steroids, they can be life-threatening in just under half a percent at the time. And so again, if about 4% of people are getting these very serious side effects, about 10% of those people can actually have a life-threatening event. And so we follow people on immunotherapy very closely because these are rare, but when they're rare, when they happen, they can be very serious. And so immunotherapy is really great, and we're trying to figure out how to use it best in ovarian cancer. It's worked a little better in some other cancers like endometrial cancer and lung cancer and melanoma. But they're very powerful agents that are really revolutionizing cancer treatments overall. And I'm going to skip this in the interest of time and just conclude that this was a very large study that really showed that these combinations of the immunotherapy here, unfortunately, was not any better than just the chemotherapy alone. This is another trial from a single institution at Ohio State, the Ohio State University, looking at a very exciting drug called lenvatinib, which is like an angiogenic inhibitor. It actually targets the receptors on blood vessels or the vascular endothelial growth factor. It targets some other related receptors, which are called tyrosine kinase receptors, and these are tyrosine kinase inhibitors. They inhibit the enzymatic activity of these, they inhibit the activity of these receptors and proteins. And this was a study combining lenvatinib with Taxol in both ovarian and endometrial cancer patients. It was for patients with recurrent cancer, and for ovarian cancer it was platinum-resistant ovarian cancer, where cancers come back relatively shortly after finishing platinum treatment. And these are the dosages. So the lenvatinib is an oral drug, and the Taxol is given weekly as an intravenous infusion. There were only 26 patients, and about 19 had ovarian cancer, 7 had endometrial cancer. There were some expected toxicities. So angiogenic therapy is known to cause high blood pressure because you're targeting blood vessels. So the blood vessels constrict a bit, which treats the cancer, but also raises blood vessels. And so that's why you see high blood pressure with many of these agents. And this is what's called a waterfall plot. And basically, this is a change from baseline. And so everyone's tumor starts here at 0. And this first little tumor here actually grew, but most of the tumors shrunk, and they shrunk quite a bit. And the blue bars are the ovarian cancer patients, and there was a 70% response rate, which means the tumors got at least 30% smaller in most patients. And that's really remarkable considering that this is a platinum-resistant therapy where, this is a very high response rate. And so to me, it's very exciting. This is called a swimmer's plot, where people are kind of swimming down a swimming pool. These are different lanes, and the arrows mean that at the time of the report, people are still on treatment, which means that the treatment also is working, and it's working for, a good period of time. And so this combination of Taxol and lenvatinib is safe and tolerable and very exciting, is being confirmed in a larger study. And if this study is available to anybody, I'd strongly encourage people to go on it. And just at the bottom, I'm highlighting another study with this drug called lenvatinib, where it's being combined with pembrolizumab, which is, again, immunotherapy. And while immunotherapy on its own has not worked that well for ovarian cancer, it's worked quite well for endometrial cancer. This combination in endometrial cancer has worked remarkably well, even in patients who don't respond to immunotherapy alone. That's a separate trial. that's being conducted right now just for endometrial cancer patients. But this study that I'm showing down here, and you can obviously have a copy of these slides so you can look this up on clinicaltrials.gov, but this study is open and accruing. We have this study open here at NYU Perlmutter Cancer Center in New York City. It's probably open at a number of centers around the country and around the world, and it's open to multiple cancer types, including ovarian cancer. It's only available to people who I believe have received 2 or 3 prior lines of treatment. I think it's 4 fourth-line treatment, which means people have to have received 3 prior lines of chemotherapy. But if this trial is available to anybody, I would also strongly encourage it because it seems like a very promising combination of drugs. Finally, just to slowly start to wrap up, I want to end with cancer prevention because, of course, the best outcome for kind of cancer in general is never to get cancer, and so to reduce the risk of getting cancer would be great. I think people know that if you have a BRCA mutation and the ovaries and fallopian tubes are removed around age 40 or so, the chance of getting cancer goes down around 90%. And so that's great for someone who's at high risk for ovarian cancer, but the side effect of having the ovaries taken out when you're around 40 is that you go into early menopause, which is not great. And so the thought with this study called the WISP study, which is sponsored by the AACR Stand Up to Cancer Dream Team, and also the PI is Karen Liu, who's the director at MD Anderson Cancer in Texas. And so here the idea is, well, if cancer comes from the fallopian tubes, could we just take out the fallopian tubes and therefore people wouldn't get cancer and they wouldn't go into menopause? And if that was true, that would be wonderful. We don't know if it's true, and so it's unproven right now. So we opened the WISP study, which is open at about 10 centers across the country. You can see them shown here, including MSK in New York and NYU in New York and Penn and Anderson and UW in Seattle and other centers here, Dana-Farber, Mayo, Chicago, Penn, and a few others have it open since. The slide's a little bit outdated. But at the time of the report, basically women who have a BRCA1 or 2 or other mutation, and here on the bottom right of this slide, you can see the other mutations that are known or thought to increase the risk of ovarian cancer. And so women who are between 30 and 50 years of age would enroll in the trial, and they would decide whether they wanted to just have their ovaries taken out, just have their fallopian tubes taken out, or have the ovaries and fallopian tubes taken out. And then if you just have the fallopian tubes taken out, the idea is that, at some point later you go back and take out the ovaries, but you're delaying menopause, for a period of time. And so about 180 people have been enrolled to date. Most people have BRCA1 or BRCA2 mutations. About half the patients had already had a risk-reducing mastectomy to reduce the risk of breast cancer, which of course is also elevated in women who are at high risk for ovarian cancer. In the salpingectomy arm where the fallopian tubes were taken out, no cancers have been identified at the time of surgery or after surgery, although the follow-up is very short, and this study does not have enough patients to prove whether or not this procedure prevents cancer. In the arm that removed the ovaries and fallopian tubes, there was one case of precancer found at the time of surgery in a patient who had a PALB2 mutation, but no cases have been found in follow-up yet. But this study is not large enough to really determine if we're preventing cancer. That would require a much larger study. This study is only going to have about 250 people in the study. However, this study called the WISP study is very similar to a study being done in Europe called the TUBA study, which is we also refer to as the Dutch study. And so just to summarize, both of these studies together, they were presented together at our annual meeting of the Society of Gynecologic Oncologists. And basically, just having the fallopian tubes taken out results in fewer menopausal symptoms, improved quality of life. Sexual function is actually the primary objective of the WISP study, and so that data is still in progress. The salpingectomy alone was not found yet to be dangerous, and so we haven't stopped the study because of that reason. The removal of fallopian tubes or the ovaries decreases cancer worry and decreases cancer distress. There's less regret about the surgical procedure in the salpingectomy arm, and as you can see down here, neither study is really powered to ask the question whether this prevents cancer, because ovarian cancer, as a whole, is somewhat of a rare tumor type. So when you look at both studies together, a number of cancers and precancers were found at the time of surgery, but no cancers have been found after surgery, but the follow-up, again, has been very small. And so the bottom line here in bold is the most important, is that we don't recommend salpingectomy outside of a clinical trial. The WISP study is now open. It's scheduled to close at the end of this year. We're looking around for ways to kind of keep it going. And in the meantime, for many years, we've been working on the real definitive study, which is very hard to design, but we finally have approval from the National Cancer Institute, the Division of Cancer Prevention, to run this study, which is called SOROC, and that's the acronym SOROC, and it's a non-randomized prospective clinical trial comparing salpingectomy to salpingo-oophorectomy to see if they're basically the same at reducing ovarian cancer only among BRCA1 carriers. It's sponsored by the NRG Oncology Group. It's scheduled to open in the early to mid part of next year. You can see the criteria here. It's for BRCA1 carriers between age 35 and 50. They will self-select salpingectomy or oophorectomy. They will be followed for up to 20 years. There'll be almost 2,300 women in the study so that we can determine if the salpingectomy is able to prevent the incidence of ovarian cancer, and that will be a definitive study that will take 10 to 15 years based on accrual to complete, but then we will have an answer, and that answer will be very important because it could help to prevent menopause in many, many people, or it could tell us that doing a salpingectomy is actually not safe and we do have to go back to taking out the ovaries and the fallopian tubes. And I certainly have my bias, but we would have to do the study to figure out what the true answer is. And so just to wrap up, the take-home points I would say are that chemotherapy combinations are showing great promise for initial and recurrent ovarian cancer. I mean chemotherapy combinations with targeted agents. The progress we're making in clinical trials is directly proportional to the success of completing them and also the amount of funding we have for translational research. So anyone who happens to be independently wealthy or who knows someone who's independently wealthy, please contribute to the funding of ovarian cancer research, either through the Ovarian Cancer Research Alliance or through any of your local ovarian cancer scientists. Lives can be saved from ovarian cancer through genetic testing and cancer prevention. Clinical trials are not always successful, but we really do learn from every trial. Even when they're not successful and not positive, we have learned how to help patients better. We've learned what drugs to give or what drugs not to give, and both of these outcomes are very important for helping women to live longer and better. Many phase 1 and 2 trials with targeted agents are available here at the NYU Perlmutter Cancer Center in New York City. We also have a number of ovarian cancer prevention studies. Again, I'd like to thank the speakers who provided most of the material for today's presentation that I have simply repurposed. And I'd very much like to thank all the patients who participated in the many clinical trials that helped to improve the success of future treatments for ovarian cancer. This is my laboratory group here on the left side, I guess. This is our clinical group. We have a group here in Manhattan. We have a group out in Brooklyn, and we have a group out in Long Island. We have NYU Langone, NYU Brooklyn, NYU Winthrop. We have a brand new hospital open last summer, all single-bedded rooms. And I also like to thank the OCRA and all the other groups that support ovarian cancer research. And with that, I'll also thank all the people who are here listening to us today, including Sarah, who I'll now pass it back over to as I try to stop sharing this. No, I just wanted to say I'd like to thank the 114 people who are still on the telephone, 113 people who are still on the webinar.
That's right. Thanks for sticking with it, everybody. So thank you, Dr. Levine. That was terrific. Covered a lot of ground there. And we do have some questions. Let's see. Let me See where to start. So you've talked a lot about clinical trials, all these exciting clinical trials. Clearly they're important. Can you give some pointers to patients on how to best bring up clinical trials with their physician if their physician does not bring it up?
That's a great question. So first of all, just bring it up. Just say, is there a clinical trial that I'm eligible for? Do you know if there's a clinical trial? How can I find out? How can you find out? How can I help you find out? Where can I go? And I'd like to say that clinical trials really are the best cancer medicine and the best treatment. And I say that for the following reason. I don't really mean every clinical trial, but most of the clinical trials that have a good chance of working are basically taking a type of treatment that is very likely that you might get anyway and adding a new agent that might just be the next best thing, or it might help the current drugs to work better. And that's really great, but it doesn't come for free. The cost is that it might also be more toxic. And you've seen a lot of trials presented here where, one, they didn't work, and two, they did work. And so we don't know the answer, but you're getting active treatment. When they don't work, the treatment is still working. It's just that the investigational agent is not working any better. So most of the time, you're not going to get worse treatment. You'll either get better treatment or you'll get just as good treatment as you would have gotten anyway. That's true for many clinical trials, particularly what we call phase 2 and phase 3 clinical trials. The phase 1 trials sometimes actually are the same thing. We're just raising the dose of a new agent in combination with the standard agents, but sometimes it's a completely new agent that's never been given to anyone, and that's really uncertain. And those types of agents really have a low chance of working. So if it's not one of those clinical trials, if it's a phase 2 trial or a phase 3 trial or some types of phase 1 trials, you're really getting real treatment. And often it's the best treatment not only because you have the opportunity to get a new drug, but also the treatment is very highly regulated. And so you can be certain that the drugs are given at the right time and the right dosages with the right pre-medications, and no one's, going to make a medical error or a mistake, which can happen sometimes because they're highly scheduled, and it's actually easy for the doctors sometimes because they don't have to think about, how much drug should I give. It's all prescribed in the clinical trials. So clinical trials most of the time are often the best treatment, and that's why you should bring it up and say, do you have any clinical trials for me? How can I find out about clinical trials? Who should I talk to about clinical trials?
That's great. And you recommend that people start asking about clinical trials early on. Right? Not as necessarily as a last ditch effort.
We have I have a patient who was just diagnosed with ovarian cancer. I saw her for the first time. She was going to have surgery, and she said, what clinical trials do you have for me? I said, look, we have a couple of clinical trials, but you should have surgery first, and this is the reason, et cetera. And after surgery is done and we know what we found and how things go, then we'll definitely talk about clinical trials, and we have one or two to choose from or the standard of care, and we'll definitely talk about them. But she, brought it up on the first visit. It was great, and I really appreciated that. And then I tabled it because I said, there aren't trials that are probably good right now, but you want to bring it up at any time.
Mm-hmm. Great. Okay, we have some questions related to Parp inhibitors. Mm-hmm. So if you've been on a Parp inhibitor, say it's your first Parp inhibitor and it stops working, would you recommend that patients consider trying another Parp inhibitor? Or can a patient assume that if one doesn't work, then another one probably wouldn't work either?
Yeah, I would not go from one Parp inhibitor to another Parp inhibitor. They're very similar, and it's probably not that likely that they're going to work. And there's two caveats. First of all, a Parp inhibitor with another drug will be completely different than a Parp inhibitor alone. So we have a lot of trials nowadays where it's a Parp inhibitor plus something else. And for many of those trials, taking a prior Parp inhibitor is allowed. And so that's a completely different story. And the other caveat is there was a study presented at our SGO meeting that I didn't show where they actually looked at a very small number of people who took a Parp inhibitor after a Parp inhibitor. There are actually 22 people who they looked at, but only 16 people had data that was available, and only 3 of those people had a response. And so, yes, there was a small chance a Parp inhibitor after a Parp inhibitor would work, but usually we have other clinical trials or other agents, and so if there's something else that's reasonable, that would probably be a better choice than going from a Parp inhibitor to another Parp inhibitor.
Got it. Okay, question. If you had BRCA testing years ago and the results were negative, would you suggest that people go back now and get retested with a multi-gene panel test?
So it's a great question. It depends, obviously, what you had done. So if you had just BRCA1 and 2 tested, and now we have about 27 genes, of which maybe, a dozen are theoretically, important, that's something to consider. The other thing to remember is that different mutations and variants of uncertain significance get reclassified. The best thing to do is really to stay in touch with your genetic counselor. You always want to update your family history. And then I think it's a personal choice. Most of the mutations are BRCA1 and 2. The chance of finding RAD51 and PALB2 and BRIP1 mutations, they're much less common, but collectively, BRCA mutations in the germline might be 10 to 15%. Collectively, the other mutations are probably 3 to 4%. But if you didn't have them tested and wanted to have them tested, it's not an unreasonable thing. I sort of have mixed feelings just because it's not that common. I think it's a personal decision, and I think either decision would be fine.
Right. Okay. Got it. Many studies report results just with BRCA1 or 2 related mutations. To what extent can we extrapolate these studies' results to perhaps other mutations that are not BRCA1 or 2 but might be related?
Yeah, that's a great question. So that's like, RAD51 or BRIP1. It's hard to extrapolate for a couple of reasons because the genes all don't work the same. We now are learning that the age at which people get cancers for the other genes is actually probably older and closer to BRCA2 than BRCA1, which is younger. There's probably a very good chance that the Parp inhibitors will work. I mean, it has been proven that Parp inhibitors do work with those other genes. And so I would say the chance from a therapy perspective, all those genes lead to homologous recombination deficiency. So they all should lead to a response from Parp inhibitors. The responses usually aren't quite as good as what we see in the BRCA1 and 2 carriers with just general HRD overall, but some of the genes, may have just as good of a response. And so it's certainly very reasonable to take that therapy. Whether you can get it covered by insurance is a different question. And so some of the studies are only for BRCA1 and 2 carriers because that's the largest part of the population, and the data can be interpreted easier that way. Other studies include anyone with a handful of genes, and so studies are just sort of designed in different ways based on who's designing it and what the company's interests are. But for the most part, anything that causes homologous recombination deficiency should have some benefit from Parp inhibitors.
Right. Okay. Thank you. This may be a question for a genetic counselor, but are doctors recommending that grandchildren of ovarian cancer patients who are BRCA mutation negative be tested for possible mutations?
Not 100% sure I understand the question, but I would say that.
I think the question is, if a woman is BRCA mutation negative and she has grandchildren, but she has ovarian cancer, but she's negative, should her grandchildren be tested for possible mutations?
No, the best person to test is the person with cancer. If the person with cancer does not have any inherited mutations, then none of their offspring, can have those mutations. And of course, you don't want to forget about the other side of the family. If someone has ovarian cancer, but the husband, has 6 brothers with colon cancer, that husband or et cetera, brothers and children should be tested for that purpose. But if you have ovarian cancer and you've been tested negative, your children cannot have inherited anything, concerning because you are negative. That's the whole purpose of genetic testing, is to know who needs, subsequent testing. And the opposite is actually more important. If someone does have a mutation identified, then all of the first-degree relatives, which are parents, siblings, and children, they all should be tested. And that's called cascade testing, because there's the opportunity to find a mutation, counsel someone appropriately, give them their options, and some of those people at the appropriate age will want to have risk-reducing procedures.
Mm-hmm. Great. Okay, I think this will be our last question. How concerned are you when a woman's CA-125 is slowly increasing over time, but she remains asymptomatic and she feels good? Is there any cause for concern there?
Yeah, that's a great question. So someone's known to have ovarian cancer, and the CA-125 was elevated at the time of diagnosis, which means it's a good marker for that person. Then we usually look at what's called doubling of the CA-125. If it doubles within the normal range, which is often less than 35, if it doubles outside the normal range over time, that's usually a strong suggestion that cancer is coming back. Now, cancers can come back at different rates. We've done some studies in this population, and usually within 3 to 6 months after there's a clear rise in the CA-125, we'll be able to see something on a CT scan. Often if someone's CA-125 is going up, we often get a CT scan. It might be negative, someone might be feeling good, but if it's persistently rising and it's a good marker for somebody, it usually means the cancer is going to come back. It doesn't mean you have to get treatment right away. When to start treatment is a very personal decision, and I think many doctors and patients have feelings about that. Obviously, the purpose of taking chemotherapy is to treat something that we can identify, and so you don't necessarily have to start treatment if the marker's going up a little bit. You want to keep an eye on things and then have a conversation with your doctor to figure out when the right time is to do some sort of intervention.
Right. Good. Thank you. Okay. I think we will wrap it up there. Thank you again to Dr. Levine for this great presentation and for taking all these questions. And thank you all for calling in today. Do take a minute to fill up the survey that will appear on your screen at the end of the webinar. All of your feedback, we read all the comments. All the feedback is helpful. And again, this has all been recorded, so you'll be able to listen to the audio and see the slides. We'll put them up on our website. For more information about OCRA, you can always visit our website at www.ocrahope.org. And that's it. Thank you all. Have a great evening. Thanks, Dr. Levine.
Thank you. Good night. Thank you. Good night.
Good night.